So I think we should start because it seems that people have arrived. And tere tulemast! Welcome to VEMU online lecture series. And today we have one of our most popular speakers, Dr. Peeter Põldre. Welcome back. Your two previous lectures has been one of the most popular lectures on VEMU YouTube channel. Lots of views, and all the feedback we have received from people is like very warm, very positive. Everyone says that it has been very, very helpful. So, as we are still caught in this Groundhog Day time loop, so it seems that those restrictions are never ending. So we really look forward to hear what would the fall and the winter bring. Should we still make our plans like plan A, B, C, D, E, as it has been for VEMU for a year and a half by now? Peeter, floor is yours, and please tell us the latest news.
Good. Thank you, Berit, and thank you all for joining. It's with a bit of mixed emotion that I'm speaking for the third time. I would have rather not had to give this particular presentation, but obviously things have not gone as smoothly as we were hoping they might have back in March when I last spoke to this particular group. First of all, thank you all. I can't see you all because I'm screen sharing. But I've seen many of your names before I had to screen share. And I also wanted to give a special shout out to friends of mine who are joining us from the Atlantic coast, as well as from the shores of Lake Damaray in the province of Quebec. So welcome, and I hope that this next time together will be informative for you. What I plan to do, if I can move this now, is I want to give a very quick, mainly Ontario-focused update since my last talk on March the 3rd, talk a little bit about variants, vaccine rates, hesitancy, and the third or booster doses, talk about vaccine certificates and exemptions, the whole issue of herd or population immunity, going to make some comments about the so-called divided society, and toward the end, I'm going to give some individual and group behavior questions for us to contemplate, as well as Berit promised, some future predictions. I'm going to start with a repeat of a slide that I showed several months ago, and that is the global perspective updated as of the end of last week. And you can see in the middle column, this is deaths per million of population, and also on the right-hand column, some estimate of population percentage vaccinated, although I must warn you that some of these denominators might not include the entire population. And I'll come back to that particular theme later on. But you can see that civilized countries like the United States are regrettably still seeing a large number of deaths per million. Canada is about a third of the US. Estonia is over 1,000 deaths per million. And I've included Sweden and Finland, mainly because obviously Sweden, you'll recall, had a very different approach to restrictions, and Finland being so closely related geographically and otherwise to Estonia, I thought those numbers would be interesting. And because I have some friends from Ukraine, this is the number from Ukraine. New Zealand continues, because of its island status and its restrictions, to have the fewest deaths per million of any reasonably sized country. The highest deaths per million is in Peru, almost 6,000 deaths per million, largely related to a variant that we're going to briefly talk about later on. And as far as the population vaccinated percentage is concerned, the leader of the pack right now amongst reasonably sized countries is Chile, with 87% of its population vaccinated. I will spend more time talking about the Canadian vaccination percentage, but 70, taking the entire population into account, is where we're currently residing. Now, you'll remember that the last time we spoke, we didn't have to speak about Greek letters, but just to bring you up to speed, the UK variant, as we knew it then, is Alpha. The South Africa variant is Beta. The Brazilian variant is Gamma. But deriving a tremendous amount of attention recently, of course, is the Delta variant, originally described in India. And interestingly, after Delta and India, it was then that the World Health Organization decided to adopt Greek letters as opposed to attributing the origin of a particular variant to a country. The official designation for Delta is B1617.2, and it was originally described officially on April the 4th of 2021. It has an enormous viral load, which becomes very important in understanding why it is such a challenge. It is much more highly transmissible than previous variants. The original variant had an R0 of about 2 to 3. Chickenpox, which many of you have experienced in your own family, has a transmissibility of 12, just to put some perspective on that. And the Delta variant has an R0 between 6 and 9. So significantly more transmissible, and hence one of the reasons why it is persisting to be a major problem for us. And there will be other variants. Now, some of the terminology that you may be aware of is that there are so-called variants of interest, as well as much more significant, hence the red color, variants of concern. Now, there's a bit of irony in the fact that we're now talking about the Delta virus, or the Delta variant, because for those of you who have been involved with math and sciences, the Delta symbol for decades has been the symbol for change or a difference. And certainly I think we will agree probably by the end of this presentation, if not sooner, that the Delta variant has caused a significant difference and a significant change in the way in which we look at the whole COVID situation. Now, it's caused us to have to brush up on the Greek alphabet. And here, just for the sake of amusement, these are the lowercase versions of the Greek alphabet. And I'll be returning to this several times later on. You might wonder what's happened between alpha, beta, gamma, and the current interest in other variants. The eta, iota, and kappa variants described in March and April are all simply variants of interest. They have not really reached a clinically significant level. The lambda variant for us is a variant of interest, but it was described in Peru and probably has a large role in the terrible toll that COVID is taking in Peru. The mu variant, which you probably have heard about, is also still officially for us a variant of interest. It was described originally in August of this year in Colombia. And just as a matter of, this is a headline from September, the mu variant is not an issue, even though it's present in Ontario, because the Delta variant is so powerful that it overrides the importance currently of any other variant. Now, the more variants we get, the more need we begin to concern ourselves with revaccination efforts, and it becomes a very significant challenge to maintaining or trying to obtain herd immunity. This is a slide that I showed in March when we were talking about the third wave, and you'll recall that at that time we were concerned about the speed of the vaccine rollout. We were beginning to get concerned about the variants with increased transmissibility, and of course there was still a great deal of interest in whether we needed public health control measures or not. I'm now going to very briefly review some of the highlights or lowlights, if you want to look at it that way, from what's happened between March of 2021 and the present day. You may recall early in March, literally 3 days after the presentation, that there was a big debate about how quickly our vaccines would arrive and trying to find the balance between the arrival and the supply of vaccines and variants. You'll recall that we were told to take the first shot no matter what was available within the province. But on March the 30th, there was beginning to be concern about the AstraZeneca vaccine, especially for those under the age of 55, because of blood clotting concerns. Later in April, the province hit the so-called emergency break with another lockdown. And that, of course, for many of us, that affected a lot of our outdoor daily activities. People already at that point were concerned about whether these actions were too little or too late. And I have a picture here from the newspaper of building the Sunnybrook Medical Unit outside of the parking lot at Sunnybrook to take care of the excess load that was anticipated at that time. At the same time, family doctors began to get involved in joining the vaccine rollout effort. And that's a topic that I'll briefly touch upon later also. But it was apparent that vaccines could not stop the third wave, primarily because of the transmissibility of the Delta variant, which by this time had clearly caught hold in Ontario. So remember that schools remained closed after the spring break. Surgeries were halted as COVID surged. We were reaching critical points with respect to the race, or the way in which it's portrayed as a race, between getting enough vaccinations and the onslaught of the variants. GT hospitals scrambled to handle spike in COVID patients needing critical care, a theme that regrettably is being produced in even greater numbers in Alberta this day. And a little bit of discussion in these headlines about the difficulty of getting vaccines in certain geographic locations. Of course, you may recall that the day after the pronouncement regarding playgrounds, golfing, and so on, the Premier had to retract his idea of annual lease stops. Now, some of you may just need to mute the microphone, as I heard a little bit of door banging or something like that. Thank you. And of course, there was political controversy about whether the advice of health experts was actually being taken by the politicians. I will not spend a great deal of time on that matter. You finally may remember that certain non-essential components of areas like Walmart and Costco were walled off many months later than it was done in other jurisdictions. And of course, the major issue, and I'll keep coming back to this, is the threat that this particular situation has posed to our intensive care units at the time of the third wave. And this was only the middle of April, the day that the golf courses, amongst other things, were closed. And many of you will remember these horrific images of the difficulty in which the population was having in terms of getting vaccines. These were lineups at the so-called pop-up clinics in various parts of Toronto, oftentimes in miserable weather conditions, like this picture that the Toronto Star shared, taken by Rennie Johnson. Now, because of the Indian origin of the variant, the feds, of course, banned flights from India and Pakistan, undoubtedly way too late, but at least from a political point of view, this was seen as a necessary step to take. And finally, toward the end of April, after much clamoring about the importance of sick pay, that was finally approved in some measure by the provincial government here in Ontario. Here, the headlines just emphasize the rapidly awareness of the importance of the Delta variant. And the other aspect of this is now toward the end of April, is that now young people were beginning to occupy intensive care units, and this unfortunate 13-year-old Brampton girl died at home while her mother was in intensive care with COVID. And these are data that basically show that the third wave, we're now in the fourth wave, but the third wave was already beginning to infect younger Ontarians. And we'll come back to this theme when we talk about the issue of children. At its peak, there were 900 Ontarians in ICU beds. The total ICU count in Ontario is about 2,200. And I wanted to pause at this point to say that in Alberta today, if corrected for the difference in population, the Alberta ICU number now is 1,100. Just to emphasize how significant the issue in our sister province in Alberta is as we speak. In Ontario, over 1,000 patients had to be sent away from their home hospitals to other hospitals to try to accommodate the ICU surges. And then, of course, confusion began to roll out amongst government authorities with respect to vaccines, the whole issue of whether you needed to have the same vaccine, the so-called mixed vaccine issue. And of course, the United Kingdom study emphasized that mixing vaccines could be done, but that may have become a detriment, as we'll talk about later, to future travel opportunities that we may or may not have. And finally, after the initial age-related pause, Ontario hit a total pause on the AstraZeneca vaccines because of the incidence of vaccine-induced thrombotic thrombocytopenia, which is the technical term for the blood clotting situation. This is a picture of the Mississauga, University of Toronto Mississauga campus, where I got my 2 vaccines. And many of you will remember this famous picture of apparently a world record single-day vaccine in one location that took place at the Scotiabank Arena in Toronto. As we saw now in this particular cartoon that was focusing on the 3rd wave, the right-hand waves showed et cetera, and surely enough, we are now dealing with one of the et ceteras, and that is the 4th wave. Now, the difference in this particular cartoon from what I showed before is that we now are at a stage where the vaccine rollout seems to be relatively plateauing. Our public health control measures are hitting a point of fatigue and frustration, and we have finally, I think, begun to realize that the Delta variant is very serious. Now, just a couple of weeks ago, we got new vaccines for the name. So for those of you who really care and are worried about your next vaccine, which we'll talk about, here are the new names now that we don't have to refer simply to the drug company name anymore. And the ones that, of course, are going to be highly relevant for us in Canada are the new names for Pfizer and Moderna. Now, what about the future with these variants and vaccines? These are the questions that I posed in March, and I will go through the current version of the answers to those in succession. The first question is, does the vaccine protect against transmission? Unfortunately, the answer to that is no. And that is simply because the Delta variant viral load is enormous, as I indicated before when we were talking about the Delta variant. What about children? It's important to realize that in those children between the ages of being born and 17 years, that represents 21% of the Canadian population. And more specifically, and of more concern right now, is that from 0 to 11 years old, it's 11% of the population. Now, amongst the 12 to 17-year-olds, current data indicates that they are already about 80% fully vaccinated. So there's a little bit of optimism here, but there's more to talk about with respect to the next cohort, the younger cohort of children. Studies were currently underway in March, but as of now, we realize that the ability to vaccinate kids between 5 and 11 is likely in Canada going to be approved by the end of this year. And of course, in between that time, Health Canada also approved the Pfizer vaccine for ages 12 and up. And as I just reported, that uptake has been a remarkably steady 80%, which parallels roughly what the adults are doing right now. Now, when I first talked about this 6 months ago, we knew that Pfizer and Moderna were having clinical trials for the age group from 9 to 18. Those were approved by the summer of 2021. And most recently, as of September the 20th, the Pfizer product in the United States was submitted to the FDA for 5 to 11-year-olds. These are 1/3 of the adult dose. They're highly effective in clinical trials. And it's important to remember that the children will ultimately need to contribute to herd immunity. And yet there is concern about what's called parental proxy vaccine hesitancy. And one of the reasons for that concern is that we've seen in some populations, the measles vaccine rate may be a warning that it's not going to be a gimme to basically have children vaccinated against COVID. Right now, children over the age of 12 are currently being vaccinated in Canada, the United States, the United Kingdom, and in many European countries, including Estonia. What about children that are younger? This is the current information that I have about countries that are vaccinating even younger children than 5. In Cuba, with a homegrown vaccine, 2 years old and up. In China, with their 2 Chinese vaccines, 3 and up. The United Arab Emirates, 3 and up. Chile at 6 years with the Sinovac vaccine, El Salvador at 6 years with Sinovac vaccine, and the United States probably within a couple of weeks at 5 years with the Pfizer vaccine. The next question I posed in March is, how will new mutations be dealt with? Obviously, new mutations occur almost invariably in unvaccinated populations. And the whole issue of any new variant of concern and adjusting the vaccine is aggressively being studied by manufacturers. But for reasons that I cannot fully explain, the mRNA vaccines are apparently relatively easy to restructure to deal with significant mutations if and when they occur. Now, we are going to talk now a little bit about the fourth wave because as Steiny Brown here mentions, the fourth wave may well divide Ontarians. And there will be a section later on in my presentation about the divided society. And as I mentioned before, Delta has changed the war with the irony of the fact that Delta was always used as a symbol for change. I'm going to return now to the talk that I gave in March and review some of the vaccine hesitancy factors and what we've done since then. We knew at the time that there would be some logistic issues getting the vaccine. At that time, it was offered in inconvenient locations, offered at inconvenient hours, unable to obtain childcare for some people who needed the vaccines. Appointments were largely offered online only, and the absence of paid sick leave kept many people away if they were afraid of side effects. Now, the reason I have the Estonian flag here is that I wanted to provide some information that a good friend of mine from Estonia produced to me just a couple of days ago. And that was a presentation that Prime Minister Kaja Kallas had given that talked about the fact that despite the fact that Estonians are heavily digitally competent, 97% of the Estonian population apparently uses some version of online activity. Despite that, in Estonia, they found that there was still a very strong need for personal connection with the physicians to be able to make their appointments and discuss their concerns about vaccine. So clearly, online is helpful, but not always the answer. Now, as of the current month, we now see in Ontario recent what are called hyper-local efforts, getting right down to the lobbies of TTC stations and various clinic locations that are not the large mass clinics as before. They're at convenient locations. There have been numerous 24-hour walk-in opportunities. And of course, as I mentioned before, there is now paid sick leave. The fourth wave, unfortunately, is most definitely here. So that cartoon that had the fourth wave as an et cetera has now, of course, been replaced by the definite reality of the fourth wave. And as many of you are probably aware, the COVID hospitalization rate has a very, very strong relationship to vaccine status. The huge proportion of patients currently in intensive care units in Ontario are people who are unvaccinated. If we look further at the whole issue of vaccine hesitancy, you'll recall that in March, these were the vaccine hesitancy factors that I postulated. Interesting enough, I put in red the whole issue of not yet approved, only emergency release as experimental. There were many people, some of them actually in quite prominent positions, who actually used the notion that because the various vaccines were only emergency release, they equated that with being experimental. And as you'll see soon, with the official approval, especially in the United States, of the vaccines by the FDA, there was an upsurge in vaccines simply because of making it officially approved as opposed to only on an emergency release basis. And we've seen that paid sick leaves were working. This is the point that I made about the fact that as of after August 24th, when the FDA formally approved the Pfizer vaccine, there was a significant uptake in vaccines as a result of those people who were hesitant because of the so-called emergency release finally being relieved to hear that it was now fully, properly approved. And here's the headline relating to the fact that there was a lot of hyper-focal focus now on how to get to people closest to home at the most convenient locations. We have heard a lot, and there's a lot of ongoing debate about mandating vaccines for healthcare workers. Recent data have suggested that this is working, not completely, but it is working. And this is an interesting article that I picked up last week from the Star. It was a whole series of quotations from individuals about why I finally got the shot. And I thought I'd share with you the answers to that as of last weekend. Online internet booking was too challenging. Now I can do it as a walk-in. I really wish to travel outside of Canada. I waited for more research. I had peer or family pressure. I had convenient locations to get the vaccine. I wanted a smaller, less intimidating location than those large caverns that I showed you earlier. I wished to go to the gym, the cinema, or sporting events. I wish to continue to being employed. And one interesting one, a court order had actually specified that one of the parents had to be vaccinated in order to visit the child. Next, I want to talk a little bit about breakthrough infections. Recall that in March, I made the observation that for any individual person, the vaccine was either going to work or it wasn't going to work. And for those people who it didn't work, there was a spectrum between having a mild infection and a very severe infection. And so we do and always did expect to have breakthroughs. Less than 100% effective protection, we knew that. And the Delta variant with its incredibly high viral load are the two major reasons for breakthrough. They tend to occur more in elderly, medically vulnerable individuals. And recent Ontario data is that between 20 and 25% of daily cases are people who have been fully vaccinated. In fact, today's number was, believe it or not, 23%, right between that 20 and 25% range. The difference is that these people almost never have to go to hospital, and rarely, very rarely will they actually die, unless they happen to be, for some reason, medically additionally vulnerable. Another story that came to my attention a couple of months ago occurred in an American seniors home. All residents in this facility had been doubly vaccinated. There was one unvaccinated healthcare worker, and 29 of the residents became unwell with COVID-19 breakthrough. 27 recovered, and 2 deaths occurred. What was fascinating about this is that 27 divided by 29 is 93%, exactly the number that is quoted for vaccine effectiveness. Another vaccine unknown: how long will immunity last? In March, I suggested that current antibody studies suggested at least 4 to 8 months, and there was a question about boosters. We now have an opportunity in September to talk more about booster and third doses. Two words that are oftentimes used interchangeably, and I will suggest to you that there is a subtle difference, although I'm not too squeamish about the semantics of this. Booster doses should be properly reserved for the general population based on the assumption that the original doses will effectively wane in effectiveness. And right now, 6 months after the second dose, booster doses are being given in Israel to anyone over 60. In the United Kingdom, anybody over 50. In the United States, as of literally 2 days ago when Joe Biden got his, over 65. In Finland, anybody over 12. And also in Quebec, if the need for travel requirements do not recognize mixed vaccines. In contradistinction, and only strictly speaking, the third dose is really the terminology that's used for people that are significantly immunocompromised and at risk. And this is based on the evidence that no matter what the interval is, these people will always require 3 doses because of their underlying disease. And Quebec, Ontario, and the National Advisory Committee on Immunization have recognized this. Although for practical purposes, there is now a sort of an equivalent use of the word booster and third, but strictly speaking, third doses should be reserved for those people who are immunocompromised, booster for the rest of us. The patient eligibility for the third doses includes people who've had organ transplants, various kinds of hematologic cancers or active treatment, recipients of a particular drug that deliberately affects the immune system. And at this point, I just wanted to put a word of caution because there is somewhat of a casual use of the word immunocompromised. When physician specialists talk about immunocompromised, we're talking about diseases where there is a demonstrated defect in the immune system's ability to function. If you recall many decades ago, the boy in the bubble, the person who has virtually no capacity to fight any kind of infection. Many people are medically vulnerable, but are not immunocompromised. But there is, of course, a mishmash of the use of the term immunocompromised, which isn't completely accurate. Right. Now, as of last week, there is a specialist referral letter that's required for cancer therapy patients, the very rare primary immunodeficiency diseases like Wiskott-Aldrich syndrome and DeGeorge syndrome, which virtually nobody except people at sick kids see, advanced HIV infection, AIDS patients, and patients on significant immunosuppressive therapies. In addition, residents of long-term care homes and in high-risk retirement homes are also going to be eligible for the third dose. And the difference between a third dose and a booster dose is really one of timing. The third dose occurs more quickly than a booster dose does. And finally, just to put even more intrigue into the argument, the Immunity Task Force is studying vaccine safety for Canadians with inflammatory diseases. There are a whole host of inflammatory diseases which are estimated affect about 7 million Canadians. Diseases like rheumatoid arthritis, for example, for whom the whole issue of whether they will benefit from either third doses or early booster doses is in play right now. So in terms of my crystal ball, and the symbol at the bottom there is my version of the crystal ball, will regular Canadians be offered a booster dose? We always fear new variants. We've gotten used to the notion of annual flu shots, and for that matter, also tetanus shots every 10 years. Not every vaccine works forever. In addition, there are evolving international definitions of what it means to be fully vaccinated. And all scientists are basically using the same international body of evidence. We also live in the shadow of the United States. So I think that it's inevitable that we as regular Canadians without one of those rare conditions will be offered a booster dose, probably at the 6-month interval after the final dose of whatever you may have received. Next, I wanted to come back to the issue of herd immunity or population immunity. And so you recall that in March, we sort of said, well, it's, is this herd immunity actually going to happen? And remember at that time, there were all sorts of estimates in terms of whether it was 60%, 70%. Dr. Fauci in the United States said it might need 80%. And he quite correctly pointed out that it's going to depend upon the effectiveness of the vaccines, and a higher percentage might be needed due to current and future variants. And remember, this was, again, my March slide just showing, what do we really think we need? There was always going to be a group that would never be vaccinated. And at that time, back 6.5 months ago, what were we going to do about children? Now, here are a variety of headlines. Kieran Moore, the new Ontario Chief Medical Officer, said 90%. The science table said 85%. I remind you that children at risk represent 11 or 12% of the population. And I'll come back to this other headline, forget the herd and just get vaccinated. So right now, if we draw another pie graph, we know that some percentage of the total population, that includes children now, are fully vaccinated. There is a group that are no, never, ever, no way. There is a group that is first dose waiting second dose, which is, I think, an issue of optimism. And in the green, the vaccine hesitant group that is relying upon vaccine availability. There are late adopters who are waiting for more evidence, vaccine approval, as we mentioned before, and of course, ever increasingly, workplace mandates and certificate restrictions. If you don't want to go to a restaurant or to a gym or to a sporting event, you might be okay. But that, as I showed in a previous slide, is a motivation for increasing the vaccination rate amongst the hesitant group. Now, this is a clipping that I took from yesterday's paper, just emphasizing that when you hear about percentage of the population, you'll oftentimes hear the word eligible population. Because right now, in Ontario, for adults, 81%. For adults, including children, it's 80.4%. But if you include all children, our total population fully vaccinated is only 70.5%. Now, that being said, I'm going to go back to this headline, forget the herd and just get vaccinated. Because I think that we may be in danger of thinking of some kind of arbitrary percentage as being somewhat misleading. It is not a magic number. We've already seen that number over the course of the pandemic rise from maybe 70 to Tony Fauci's 85, and now Kieran Moore's 90%. I think it's useful only as a guideline to encourage as much vaccination as possible, because ultimately the immunity formula depends upon the R0 of the virus, its transmissibility, whether there are new variants of concern, the effectiveness of the vaccine being used, and the percentage of the population being vaccinated. So if you look at those three factors, it's only the percentage that seems to be getting the headlines. And what I would be afraid of is reaching some kind of so-called magic number and then not seeing appropriate restrictions being removed. So I use this as a caution just to say that let's not rely upon reaching some kind of number only to find that some of these other factors are now in play and cause us still to have to be concerned about the status of the pandemic. Vaccine certificates, passports. And I've crossed out the word passport because I've come to realize, or I've come to accept myself, that passport may not be the most appropriate word, simply because, first of all, it has a restrictive connotation to it, as well as it's something that in most jurisdictions has federal authority. So I've now begun to prefer the use of the word certificate myself personally. And you will recall that in March, at the end of my presentation, I did discuss and improperly use the word passport to suggest that this may have to be coming. And sure enough, over time, it eventually did come. I put these pictures up just to remind us that many of us, if we look through our drawers, will realize that we've always had various certificates of vaccination to allow us to have proof, whether we're traveling or not, in terms of what vaccines we have received. And so over the course of the last several months, there were various initiatives to encourage the creation of so-called vaccine passports. The science table itself touted a vaccine certificate. This was in the middle of July. The government at that time said that that little sort of tissue-like slip of paper was enough. And of course, Premier Ford was completely adamant on the 12th of August that he wasn't going to budge on the whole issue of certificates. And then a couple of weeks later, he finally decided that it was time to bring in the vaccine passports. And the government, instead of borrowing apps from other countries and jurisdictions like Quebec, decided it's going to create its own in-house passport that will be available to us on October the 22nd. And finally, our neighbors to the far west, Premier Kenney finally introduced the vaccine passport just recently, largely as a result of the enormous pressure that was occurring in Alberta hospitals for COVID. It was going to cause triage situations. Paul Parks, who is the emergency head of the AMA, already has admitted that various triage-like functions have begun in Alberta and regrettably will have to continue. I began to draw this particular map a couple of weeks ago, and at that time there were still a fair number of discretionary for business only, but over time, virtually every province over the last several weeks has turned into a mandated situation. And I do believe I may be inaccurate. I think PEI may also be going in that particular direction. Now, one of the issues with the certificates is that there are provisions for medical exemptions. But as the headline reads, medical exemptions will not be easy to get. And to the credit of the College of Physicians and Surgeons of Ontario, Nancy Whitmore, the registrar, sent out a message to all physicians a couple of weeks ago that basically said there are very few acceptable medical exemptions to the COVID-19 vaccination. For example, an allergist or an immunologist confirms severe allergy or anaphylactic reaction to a previous dose of the vaccine or any of its components, largely PEG, which is polyethylene glycol, that can't be mitigated, and a diagnosed episode of myocarditis, pericarditis after receipt of an mRNA vaccine. That's it. And that's been replicated in most other Canadian provinces in terms of legitimate causes for medical exemptions. Yes, last week at Sunnybrook, I heard a presentation that talked about the Sunnybrook data. Sunnybrook has over 11,000 employees and only 2 medical exemptions have been granted, presumably on the grounds of one of those criteria that I read out before. Now, there was a concern and continues to be concerned about fake exemptions could be a problem. And it is at this particular time, between September the 22nd and October the 22nd, a very hard expectation to imagine that some poor innocent public member doing door screening for his or her restaurant or place of business has to assess a medical exemption note from a doctor. And in my opinion, and I think this is coming, the medical letter of exemption should be verified by a ministry authority, and it will have to be incorporated into the QR code that is expected toward the end of October. If that doesn't take case, the medical exemption issue is going to provoke an issue for those individuals responsible for screening at the door. I'm going to speak a little bit about what I've called here group and personal behavior. Back in March, we talked about, what if we don't have herd immunity? What am I going to have to continue to do? And also as a reminder, even if you've been vaccinated, for you, the vaccine effectiveness is either 0 or 100, and you're still going to be at risk. And that's especially now the case with the Delta variant floating around. And so I suggested at that time back in March that you would still have to have some kind of individual risk assessment because of your age, whether you have a vulnerable condition, or for those people who have a truly immunocompromised position, even more of a risk assessment. And I mentioned at that time also that you have to decide whether you're going to be willing to forego some social interactions, wear a mask, and when it comes to virtual or remote meetings, will they be sufficient for either my professional or my social needs? And will there be some kind of hybrid available for either an in-person or a virtual meeting in the future? Today, I wanted to just pose similar questions, perhaps with almost similar answers. For public group indoor gathering activities, for restaurants, gyms, and sporting events, where we know that the demonstration of vaccination status is now mandatory, the question still remains, will that vaccine certificate be checked at the door? Will the vaccine certificate be enforced at the door? And will wearing a mask be expected until one orders, for example, your restaurant meal? And we are aware over the last couple of days that there are still hundreds of businesses that are deliberately flaunting the mandate to check for vaccine certification at the door. And there may be some questions about that later. For private group indoor gatherings, and this is perhaps something that would be related to a seminar in the future for a doctoral college, for example, will the organizer require a vaccine certificate? Will the organizer collect contact information as is now expected in York County? Will physical distances be in place? Will wearing a mask be expected? And will virtual participation be available? In other words, a hybrid method if there are going to be in-person gatherings. I wanted to also talk a little bit about foreign travel. And this is largely my own thoughts in terms of how I go about thinking about foreign travel. First of all, travel insurance. Will you be able to get cancellation insurance prior to the trip? In other words, if you were to inadvertently become COVID positive, or if the destination COVID status were to radically change, will the travel insurance cover medical care if needed, both at the destination, not only for COVID, but for non-COVID conditions? Because the status of the hospitals, and especially their more intensive care units, may be relevant if you suffer a non-COVID problem while on vacation or traveling. Likewise, will the insurance cover a trip extension if you were to become COVID positive and had to quarantine at your own expense, presumably, or with relatives if you were going to some place where you had relatives, realizing that you wouldn't be able to get back on the plane until you'd finished the quarantine period and were shown to be COVID negative. In addition, I think it's very important for all of us to be aware of what the up-to-date entry requirements of the destination will be. What is their definition, that country or location's definition of fully vaccinated? How are they dealing with mixed vaccines? We know that there are several jurisdictions that do not accept even a mixed mRNA vaccine, such as Pfizer, Moderna, or Moderna, Pfizer. Do they have any testing pre-arrival? Is there a quarantine arrangement pre-arrival? One, I think, needs to be aware of what the up-to-date status of the destination is, not just by country, by specific region. For example, if one was traveling to the States, what is the vaccine and COVID status, as well as the hospital status in that particular state location? What are the medical resources like? And what are the expected public health precautions at that particular site? And then on the way back, presuming that one wants to come back to Canada, one needs to know what the up-to-date re-entry requirements by the Canadian government will be. And finally, at a personal level, when I travel somewhere, who will I be interacting with? If it's only with your immediate relatives and you know their status, that's a big difference from going somewhere where you're going to have uncontrolled ability to deal with people for whom you will not know the vaccine status, except at a generic level by looking at what the status might be in that particular country. Will you be willing to still wear a mask despite the fact that you may be out of place if a country does not have, a destination I should say, does not have a lot of masking going on? Can I extend my stay in quarantine, not just freewheeling, if I turn out to be COVID positive during the course of my trip? And if I do need to stay in quarantine away from home, what will I miss at home? May not be an issue for a retired individual, but somebody who has some kind of work obligations may want to contemplate that. Now, I'm going to be coming toward the end, and I want to speak a little bit about the so-called divided society. Many of you will have heard or seen sentiments such as captured here. I'm not going to read them all, but wording like, I have no empathy left for the willfully unvaccinated, let them die. Unvaccinated patients do not deserve ICU beds. And of course, cartoons such as this that emphasize the current controversy is occurring between people who believe in the power of ivermectin, the horse dewormer, other interesting suggestions such as fish tank cleaner, or in the case of the former American president, Lysol, and of course, an oftentimes concomitant rejection of the importance of COVID vaccines. We see debate occurring even amongst union members. So the TTC union members were urged not to disclose vaccine status, whereas Jerry Dias at Unifor suggests vaccine mandate. So even amongst constituents that usually speak with a different voice, there is division. Vaccine deadlines are now looming for hospital workers. This is headlines from the last couple of days. Only 56% of transit workers disclose status, and yet today, breaking news, the TTC union backed down and now urges members to comply with the vaccine mandate. Now, the picture on the left was taken by my daughter, Christina, from her office when the anti-vax, anti-passport protesters were marching toward Queen's Park. And it's my view that these individuals live and think in an alternative world. They have a fundamental different ideology that creates a very different way of how they evaluate scientific evidence and how they evaluate the balance between individual rights and public responsibility. And there is, of course, a strong interrelationship between that and various other conspiracy theories that tend to accommodate and also accompany these particular protests. Now, historically, society has reacted to these kinds of situations before. And I would suggest that one of the primary, if not the most important human instinct is to survive. And danger posed by infectious agents is not new to this particular pandemic. One will look at the Bible and see that when leprosy was the scourge, they were sequestered into colonies. The word quarantine comes from the 14th century. In 1377, the city-state, I guess, of Dubrovnik had patients with the plague. And it mandated a 40-day isolation of any merchant ships that were arriving from infected ports, such as Venice. And it is that 40 days that, in fact, has given us the word quarantine from the Italian. So right now, the lack of a vaccine certificate is going to cause stigmatization. And in fact, it is going to sequester those individuals who do not have a vaccine certificate from non-essential activities, such as restaurants, gymnasia, sporting events, and so on. And ultimately, if the employment mandates hold true, unemployment. Now, I thought it would be useful to look at a couple of other personal versus societal rights, just to put this matter, at least from a physician's point of view, into perspective. We know that smoking tobacco is not only bad for you as an individual smoker, but also there are dangers of secondhand smoke. So over the decades, we have seen significant restrictions for locations in which smokers can smoke. We know that drunk driving is bad, and it affects, unfortunately, innocent bystanders. One has to think about the Neville Lake family, for example, where 4 individuals were killed by a person who was driving at speed and very intoxicated. And those caused criminal charges and license suspension. And we know that unvaccinated people in public spaces do put innocent bystanders at risk of infection. And therefore, the restricted access via vaccine certificates is, I think, an interesting balancing act between not putting them into a colony somewhere, but allowing them to function as safely as possible, but not putting innocent bystanders at risk. Now, we have a compassionate and non-judgmental access to healthcare. We treat the smoker's lung cancer. We resuscitate the drunken driver who is not wearing a seatbelt. And we try to salvage the life of the anti-vaxxer who contracts COVID-19. It's very interesting to see that we've gotten recently some preemptive guidance from the Ontario Human Rights Commission about the whole issue of what they call singular beliefs. And that is that a person's own defined preferences or singular beliefs do not have the right to accommodations under Ontario's human rights law. In other words, I cannot go and say that, listen, because I'm a kind of a Lutheran, in my belief somehow I've read the Bible and I think that, that I shouldn't get vaccinated and you're discriminating against me. That would not hold water. That would be viewed as a singular belief, whereas if there was some kind of well-documented, well-understood issue, such as Jehovah's Witnesses, for example, that would not be considered a singular belief. So to their credit, the human rights tribunals have decided to get in front of this particular issue in case those people who do not have vaccine certificates go after this from the perspective of being deprived of human rights. And finally, I wanted to talk about what happens after the pandemic, the so-called endemic. I wanted to remind you, as I did, I think, in March, that currently we have various other endemics ongoing. The descendant of the Spanish flu from 1918, the influenza A that we have right now, prior to the pandemic, still killed about 650,000 deaths per year globally, including about 4,000 individuals in Canada. And it requires, for most people, an annual vaccination. We also have endemic cold viruses, rhinoviruses, that are also part of the coronavirus family. And typically, of course, these produce mild symptoms. Ultimately, I think the concern that we're going to have in the endemic phase will be hospital capacity. And as a reminder, pre-pandemic, back in 2019 before, we did see seasonal flu impact on hospitals. You may remember that in December and January, virtually every year, we had overcrowded emergency departments that led to so-called highway medicine. This was a very minor example of hospital capacity being influenced by what was then, by current standards, a relatively mild endemic. And of course, as the theme has gone on and on and on, the current unvaccinated population is a major strain on hospital resources. And this particular graphic, I wanted to sort of highlight that prior to the pandemic, with normal ICU capacity, we were able to deal with patients with trauma, with cardiac conditions, with cancer conditions, and significant obstetric complications. During the pandemic, a significant chunk of that ICU capacity was taken up by patients who were being resuscitated or attempted to be resuscitated for COVID-19. And in our endemic phase, the big question mark in red is how much will the endemic version, the seasonal December, January that we've seen with regular flu, how much of that will in the future compromise normal ICU capacity? As a reminder, ICU resource is not simply beds. There is a very significant concern about human resources burnout, especially highlighted with highly qualified intensive care unit nurses. There are redeployments occurring for people that are not fully qualified to be working in the ICU. There is a very significant concern about nursing retirement. There is resentment in the profession about the fact that in Ontario, at least, they're only limited to a 1% raise year after year. And indeed, for many of you who have seen the headlines, Quebec is now offering bonuses of up to $18,000 to keep nurses in their struggling healthcare system. So the ICU resource will not be solved simply by buying more beds. Beds by themselves do nothing. They need human resources. And it's not just nurses. There are respiratory therapists and various other support staff that are critical in maintaining the capacity of an intensive care unit to take care of patients who have trauma, who have cancer diagnoses that need major surgery, likewise cardiac surgery and obstetric problems. So when will we reach that point of endemic status? And here again, the symbol up in the upper right-hand corner is my very fictitious crystal ball. If we assume that we have no new variants of concern, assuming that we can start vaccinating children from 5 to 11 at least by the end of this particular calendar year and have a steady increase in the total population, the best estimates that I've seen is that in March or April of next year, we will reach an endemic status. But those assumptions are still big if assumptions. And one of the things that we clearly should have learned over the course of the last 18 months is that there is predictable unpredictability with COVID and its variants. I want to conclude with this particular slide. It's got some symbols that I will explain. You can see that we've now reached the mu stage of the Greek alphabet, with delta still being very important. And we really don't know at this particular point which of the remaining parts of the Greek alphabet will become important as variants of concern. The hurricane symbol is there to remind us that hurricanes get named every year. There's an international group that gets together to decide alphabetically what the hurricane names for a particular year will be. And we may well, after we run out of the Greek alphabet, end up having to have some kind of hurricane-like system for naming new variants. The other thing about the hurricane symbol is that unfortunately, hurricanes are very predictable in terms of their occurrence. And likewise, most infectious disease epidemiologists believe that variants will occur somewhere in the world. Hence, we have to return to an issue that has really not been front of mind very recently, and that is vaccinating not only the well-off countries of the world, but the poorest countries of the world, but still represent the vast majority of the world population. Because a variant of concern can occur in some obscure, faraway place, not even necessarily a tourist destination, and infect the world in very rapid sequence. And the reason I put the Chinese flag there, again, as a geopolitical issue, is that the Chinese have invested enormous amounts of resources in distributing their Sinovac and Sinopharm vaccines to many, many parts of the world, especially Africa. And so, although right now this is really essentially a worldwide public health issue, there are also very important geopolitical issues that we have to keep in mind as we try to resolve the issue of making sure that we ourselves are safe, but also find a way of helping the rest of the world to also be safe and go into an endemic phase. With that, I wanted to thank you, and I welcome any further questions or discussion about what we've talked about. And I'm going to stop screen sharing at this point.
Okay, thank you, Peter. Thank you so much. Very, very interesting talk, as always. So now if you have questions, there are two ways. First, you can write them in the chat here. There's a button on the bottom, but you can also raise a hand or unmute your mic and ask your question. So whatever works best for you. Until people think about the questions, I would have a question to you, Peter. How to fight this misinformation, which is all over the world, on social media, politicians even sometimes are using it. How to fight that?
That's an excellent question that I don't have a very compelling answer for. I think, first of all, it's important to realize that some segment of the population is still genuinely trying to understand what's going on. And so the way for that particular, the hesitant group of population to deal with misinformation is to seek appropriate information. I think for the people that are, as I mentioned before, in an alternative world, I don't think it's worth a great deal of effort to try to convert them, because their alternative world has a very comprehensive explanation for anything that you would postulate as your version of the truth, including things like the whole thing is a hoax. And it's very difficult to expend too much energy on dealing with something where there's a fundamental misunderstanding. It's almost like trying to talk two different languages. So I know that's not a very good answer, but it's the best one that I can think of.
Right. Peter Einola, you can ask your question now.
Peter, good evening. Thanks for the talk. I got in about halfway through, but and I saw your slide on the on travel and doing the personal risk assessment.
Yeah.
So I put you on the spot a little bit. All things considered, if you had the opportunity to travel to Europe right now, would you go?
I wouldn't myself yet, but I think that the decision to travel somewhere, like for example, going to Estonia, I think has a lot to do with the question of why. If, for example, I had a relative who was very unwell or some other compelling personal reason, and that's a decision that everybody has to weigh by themselves. It's not something that anybody else can really tell you. There's also, of course, the fatigue that we're all experiencing. We all desperately want to go somewhere, whether it's to visit relatives, to see new sites, and so on. So I think that those questions were, or those points that are in those 3 slides relating to travel were intended to simply raise points that one has to be aware of. But to answer your question more, on a personal level, if I had a reason to go to Estonia, for example, right now, I don't have to worry about if I get quarantined, I'll probably be in one of my relatives' homes instead of in a hotel. And so and the reason for going there was something very personal and very meaningful for me, I would go. but that's just my own personal view. But I would urge all of you to sort of think about those questions that I posed, including the issue of travel insurance. As I've explored travel insurance for our potential upcoming travels in 2022, strange things happen. For example, the travel insurance that you get with your premium credit card relies upon what the Canadian government status of essential travel or not essential travel is at the time you do your booking. So you might not get a refund if you had to cancel because your destination place became a COVID hotspot, or you yourself inadvertently, even if you're double vaccinated or fully vaccinated, were to get COVID. Little things like that that we never thought of before have now changed very dramatically because of the COVID situation. Hope that helps.
Yeah, thanks, Peter. Mikko raised a hand, please, go ahead.
Hey, Peter, great presentation as always. I have a question. I'm not sure if you know the answer, but is there sort of a central place that you can determine what countries accept this mixed vaccine? Or is this a total hodgepodge and very difficult to try to figure that out at this point?
Good question. I'm not aware of a central spot, but I think that what I was referring to updates, I would, if I was traveling somewhere, I would within a couple of days of my travel, go to whatever seems to be the legitimate national website for that particular destination and try to find the information that way. And if necessary, and I hope I'm not being too bold about this, if you're not getting the answer, try calling the consulate of that country or the ambassador for that country to double check on something like the mixed vaccine situation, because it may not always be apparent on a particular website how they would deal with mixed Pfizer. Now, we've heard, for example, that Christina Freeland, our deputy premier, is allegedly making efforts internationally to try to recognize the issue of mixed vaccines. And of course, one would hope that because there was a fair amount of mixing in other civilized countries, also like the United Kingdom, that from a practical economic point of view, there would be more acceptance of the fact that mixed vaccines were pretty reasonable to give. But many of you may have seen the story a couple of months ago. Trinidad and Tobago, for example, absolutely rejected a person going to his mother's funeral with a Moderna-Pfizer combination. Absolutely rejected it. Nothing you could do about it. And remember that no matter how powerful we think Canada is, every country is its own sovereign state when it comes to those entry requirements.
Thank you.
Now we have two questions in this written in chat. First comes from Madis Krem, and he asks, are the vaccine makers currently designing new variations of the vaccine and their boosters? And if so, what will this do the value of the world inventory of the current designs?
I don't know the exact details in terms of how much of a change has been made in the current major vaccines. I do know that the capability of changing to if there was a significant variant of concern that arose, would come forth. Most of the evidence that we have right now is that the current vaccines, if given in proper dosing, are effective against the Delta variant, as effective as it can be. But just remember how powerful and transmissible and what the large load of the Delta variant is. That's why we're not seeing 100% coverage. Probably never will. But you can believe that it's in their vested interest financially, of course, to be able to keep on top of that kind of situation as best as possible. And my understanding of the mRNA technology is that one of the powers of it is that it can change more quickly than the old-fashioned live attenuated vaccines.
And another one from Lili Valge-Kasteli. Thank you, Peter, for the clear and detailed presentation. When do you anticipate the third vaccine booster will be available for all? There is talk about it being 6 to 8 months after the second dose, which is the time frame some of us are in having received the second dose in February.
Right, so yeah, 6 months is the current, seems to be the current consensus for when the booster dose should be given. The United States already started with people over 65, as well as a whole list of other defined populations. My guess is that Canada will probably be within the next month or so. And you're absolutely right. As we begin to think about when most of us got our second dose, if we got a second dose of one of the mRNA vaccines, then it'll be about time. By Christmas, for example. I mean, many of us probably were in that sort of April, May, June splurge once we got vaccines available in Ontario.
You started your presentation with the statistics from all over the world about deaths and the cases. Mm-hmm. What's the case with New Zealand? Why the numbers are so small?
Well, the general accepted answers to those questions are, one, they're an island, but two, because the UK is also an island, but two, they very early on got very aggressive about restricting travel and quarantining individuals, even their own citizens who happen to be coming back. And so I think those are the two combinations. You may recall in the media a couple of weeks ago, they were horrified when they were up to 20 cases a day in the country. And that number 5 per million has been consistent over the last several months since I was doing the talk in March. Despite that, their vaccine numbers are not yet very high because they didn't really think that vaccination was a major priority compared to their very restrictive ability to keep themselves in check as an island. And the population, I think, bought into that. Because they didn't want to travel and they didn't want to have people coming in. So that particular mentality, by the way, is not dissimilar to what our own Atlantic provinces did. Because they were, even though they're not physically an island, except for Prince Edward Island, they were able to, by restricting the border between New Brunswick and Quebec, they were able to almost create an island-like situation for themselves for many, many months, as you'll recall. And they're going back to that now, if I recall, from the last couple of days.
Hi, Peter. It's Alan. Thank you very much for excellent talk, as always. Any insights as to why ASD is lagging so far behind in vaccinations? Early on, they were keeping up with the rest of Europe and with Canada. Now I see they're at about 45% and Canada's at 70%. Any insight as to why the hesitancy, or is it something to do with the supply, or any insights?
I really honestly don't have insights. I wouldn't jump to the conclusion that it was all hesitancy. It may be a supply issue because, for example, you recall that they are now, Estonia is vaccinating, kids from 12 and up also. So it's not like there's a public policy against vaccination. But I can't speak to it any more detail than probably, hopefully, supply issue as much as hesitancy. I would hope that it wasn't hesitancy to that degree. But I have no accurate information to answer that question.
Yeah, following the Estonian news, like daily basis, I could tell there is some hesitancy. They kind of get to the point where those people who decided to vaccinate, they've done that. And they're now the people, they have to, get them to vaccinate them. But there is actually a hesitation among Russian population who are following Russian news. There are hesitation also in the certain southern part in Estonia, where also those numbers are going up because the vaccination numbers are quite low. So they're like combination of different problems, actually. Yeah.
That's oftentimes the case. It's sort of multifactorial. And of course, as we've seen in Ontario, certainly the combination of the certificates and workplace mandate have begun to pick up the vaccine rate reasonably dramatically. But of course, now that you're going from your 80s to trying to get to the magical 90, and I warn people, I think we could be in trouble if we all of a sudden one day hit 90 and nothing changes in terms of the risk that we have to go through. So I would view those as sort of guidelines encouraging but it's not like the world is going to change when we go from 89.9 to 90, especially including the little ones. That's the big issue. Remember that kids right now in Ontario are submitted to already 9 different vaccines. The Toronto Public Health Officer, Elaine de Villa, has mentioned that adding a 10th should not be a problem, but there's no doubt that there will be some carryover from the hesitancy of adults to, of course, the kids, because the kids are not free agents themselves at that young age.
So the next question comes from Mikey. Look, please, Mikey.
Peeter, thank you for, I've avidly listened to each of your presentations. I have a question about pregnant women. The hesitancy about getting vaccinated and then going in to give birth. What are the risks for these women? I have a vested interest here.
Yeah, the recommendations from the Canadian Society of Obstetricians and Gynecologists is, first of all, to discuss individual issues with your obstetrician gynecologist, but at the same time, there is abundant evidence that pregnant women who get COVID are in very dire straits. So that's a problem from the point of view of if you happen to get it. There does not seem to be, I've not seen any evidence that the vaccine itself has posed any risk to the pregnancy.
My follow-up question was, when this woman goes in to give birth and she has not been vaccinated, is she at higher risk in that operating situation?
Oh, I don't think so. I think if you're saying that if you're unvaccinated but have to receive health care of any kind, the hospital setting, I think, is pretty rigorous in terms of its attempt to try to control any spread within the hospital. Okay. There are, of course, have been hospital outbreaks, typically in units where patients are dwelling. One of the interesting things about labor and delivery units is that your length of stay in those units tends to be very, very short, which is good from the point of view of not dwelling in that particular environment. And of course, it's an environment that for over a century, ever since the work of Semmelweis, has been acutely aware of the need for antisepsis. So relatively speaking, I think that if you're unvaccinated and you have to go in for a delivery, that should not be a concern for you.
Okay, thanks.
So Miko has another question, please.
Just wondering about moving from a pandemic to an endemic. Is right now, let's assume that the Delta variant is sort of the one that sticks around and there's not another variant that kind of comes over and knocks it out. What happens when you move to the endemic? Does the Delta variant just sort of stay as your main COVID variant, or does it sort of dwindle off if there's no, if people are vaccinated and you have a not mentality, but does the Delta variant just kind of slowly just disappear, and then like maybe another less strong variant kind of takes over at that point?
Yeah, theoretically, I mean, the notion of herd immunity is that there is so little that is transmitted, because if everybody was theoretically vaccinated, there could be no transmission. But as long as we have an unvaccinated population, there will still be some ability to transmit. And that's in the slide that I showed, the little bite out of the blue ICU capacity, that's the red part. In other words, we do not know whether it's Delta or some other Greek alphabet letter later on that may, over the course of time, endemically. The nature of the word endemic means that there will always be, to put it in lay terms, sort of a low grumbling rate of infection. And I bring back the example that seasonal flu does that. Seasonal flu is endemic. And you see it especially in January, in December, January, sometimes earlier, sometimes a bit later. And it does affect our hospitals, but usually not at the ICU level. usually because people have to be put into auditoriums and hallways and so on and so forth. So we know what an endemic is like because we have endemics with seasonal flu. So that would be the situation. And of course, we know that the flu changes virtually every year. There isn't an expectation amongst the virologists that I've heard about that is going to be always quite the same change. So we don't really know whether we're going to need an annual COVID booster or whether that can be at some different interval. It's part of the great unknown for this whole virus. Does that help?
Yeah, thank you.
So any other questions? I can't see any raised hands. If not, then suur tänu. Many thanks.
Right. Thank you all.
What do you think, Peter? Should we book a next lecture sometime in February or March?
Well, when you asked me that question in March, I said, I hope not, but I will be keeping myself available in case it's necessary again. But in the meantime, I would urge everybody to still think about those individual risks. Don't be afraid of wearing a mask, maintaining some kind of distance. And I think that we will enter a world in which events like this, which have garnered, I think, a very generous audience, thank you to all of you, can be done without everybody having to trek down to 3 Madison. So, you know, one of the very few silver linings I think we may come to from now when we look back on the years of the pandemic is to realize that there are various different ways of getting together for certain kinds of events that we never would have thought of doing before. So that's the positive note that I wanted to end on.
Again, aitäh. Thank you, Peter, and everyone. Thanks for coming. There's some applause I can see.
I can see my friend Bob Lester in Halifax. Hi, Bob.
And stay safe, everyone.
Thank you.